Hello everyone, this is Prasangra Dado, Project Coordinator of Educational Services for the Association of Community Cancer Centers. I want to thank you for joining us for the webinar entitled Optimizing Enteral Nutrition for Oncology Patients as part of ACCC's Establishing and Improving Cancer Nutrition Programs in the Community Cancer Program webinar series. This webinar is supported by Abbott Oncology. Today's webinar has been designed to help you understand which patients may need enteral feeding and the red flags that call for a dietitian's intervention. Please note that this webinar will be archived online for your reference and to share with your colleagues. I want to remind you of the webinar tools for today's session. You will notice on your screen that there's an Ask a Question text box located on the lower left corner. This is where you ask the speaker questions. Please type your question in the box and hit the Submit button. Your questions will only be seen by the speaker. This will allow you to ask questions throughout the presentation, and at the end of the session, we will also leave time for a Q&A. If you'd like to download a PDF version of today's presentation, you can do so by clicking on the drop-down menu located in the upper left corner of the page. At this time, I would like to introduce our presenter for today's webinar, Theresa Fessler. Theresa is a nutrition support specialist at the University of Virginia Health System Morrison Healthcare. Her bio can be found in the upper left corner of your screen. At this time, I will turn the session over to Theresa.
Well, hello, everyone. I'm really glad to be able to speak with you today. I'm going to give you some information to help provide great care to your patients who have cancer and who need enteral nutrition. When I talk about enteral nutrition during this talk, I'm going to use the term EN to stand for enteral nutrition. During the past 11 years or so, about 99% or more of my patients use enteral or parenteral nutrition, so it's an everyday thing for me. And I've been working with enteral and parenteral nutrition for about 21 years. I have 4 main objectives today, and 2 of them are red flag items to help you to know which patients need an RD or a registered dietitian and who needs enteral nutrition. The other 2 objectives are going to be more practical-based to help meet goals and to prevent and deal with problems for patients who are getting enteral nutrition. The first objective is recognize nutritional risk factors that indicate the need for a registered dietitian. Screening and assessment tools that we use now use the criteria that will identify patients at risk, and those are the same criteria I use every day with my patients. All of these screening tools use weight history, appetite, food intake, GI symptoms, and so forth. In April, the second lecture in this Nutrition Oncology series, Roan Levin spoke a lot about nutrition screening and evaluation. And so I advise you, if you want more information on the subject, to go and look at her archived version. Overall, the malnutrition screening tool and the patient-generated subjective global assessment have been validated in the oncology population. At UVA Health System, we categorize our patients into 3 categories of malnutrition: mild, moderate, or severe, based on the amount of weight loss that they've had in the past month or so, and based on the amount of food they're able to eat, whether or not they have muscle wasting or loss of subcutaneous fat, and also their functional capacity. A lot of my patients who are in the oncology population do fall into the severe malnutrition category. For surveillance and screening for knowing who needs an RD, what we do is we look for information just like the regular screening criteria. We look for weight changes, GI problems, and potential problems with GI function, such as maybe maldigestion or malabsorption if a patient has had gastric or GI surgery in the past. And patients with a more advanced stage of cancer are more likely to need nutrition intervention. The bottom line is an RD is needed for any patient who is identified at risk. I'm going to introduce for you a clinical case, and this is based on a real patient. And you can kind of think about this patient throughout the webinar and think about what you might do for his feedings and what you might look for monitoring and taking care of him. So Greg is a 55-year-old man with a newly diagnosed esophageal cancer. He's had placement of a central IV access port, we call that a portacath, and a jejunal feeding tube. Plans include chemo and radiation therapy, and later an esophagectomy. He's 5'10", he's 237 pounds, or 107.7 kilos. His ideal body weight is 75.5 kilos, and his usual weight 4 months ago was 285. When I first look at him in the hospital, he doesn't look malnourished at all. He tells me that he cannot eat any solid foods, and now he can barely take fluids without a lot of pain and reflux. He's been eating soups, liquids, and soft foods. His stools are normal but decreased in frequency, and he complains of some gas. His urine looks dark, and he complains of some periods of feeling weak and dizzy when he goes from a sitting to a standing position. Objective number 2, who needs enteral nutrition? I'm going to help to identify patients who are at risk and who may need or who are using enteral nutrition. I've categorized 3 major groups of patients in the oncology population who need enteral nutrition. And the first and the most frequent users of enteral nutrition would be patients with severe dysphagia. And this would include head and neck cancer patients, patients with esophageal cancer, and those with dysphagia due to other illnesses. For example, you might have a patient I did recently who had a stroke prior to her diagnosis for cancer. So she already had a PEG in place and was using that before she even was diagnosed with cancer. There's nutritional problems documented in 40 to 57% of head and neck cancer patients at the time of diagnosis. And for esophageal cancer, more than 78% have been found to be malnourished. The second group of patients that need enteral nutrition, not quite as often, but I do see these patients, are anybody who's had disruption in some way or another of the GI tract. For example, patients with cancer of the stomach, the duodenum, pancreatic cancer, or cancer that's in the bowel. These patients may have gastric outlet obstruction, they may have duodenal obstruction, or a blockage or mass somewhere else, which prevents them from eating orally or from getting enough nutrition. The third group is patients who have digestive problems after cancer treatments, and that would be patients with different types of cancer that have required radiation to the lower part of the abdomen that affects the bowels. Some examples would be rectal, gynecologic, and bladder cancers. And what can happen after a lot of radiation therapy is they might develop radiation enteritis or even fistulas or strictures. I'm going to talk briefly about some predictive factors for the need for enteral nutrition. In the head and neck cancer population, observational studies are in the literature, and I've noticed this also in my practice, that patients, it depends on where the cancer is, such as the oropharynx, the larynx, the hypopharynx, neck, oral cavity. Those areas are more likely to need enteral nutrition. Stage 3 to 4 cancer, more than earlier stages. And the size of the tumor matters. The bigger the tumor is, the harder it is going to be for them to eat. Surgical procedures that are associated with enteral nutrition need would be flap reconstruction, neck dissection after radiation therapy, and those with a tracheotomy. Also, patients with low body mass index, and those who have had chemotherapy or radiation therapy added to their regimen. For the esophageal cancer patients, the most likely ones to use and benefit from enteral nutrition would be those with a low body mass index and those who have developed an anastomotic leak after their surgery. Usually an esophageal cancer patient will be on enteral feeds for only a few weeks after their surgery. But if they develop an anastomotic leak, they might be on enteral feeds for a month or more, and sometimes even several months. There are a lot of descriptive studies in the literature that talk about the benefits and risks of PEG tubes, that stands for percutaneous endoscopic gastrostomy. The benefits that have been documented are decreased weight loss, optimized body weight for obese patients, fewer hospitalizations for nutrition and hydration problems, and most importantly, less interruptions in treatment. Nutrition helps keep people strong enough to continue on with their therapies. Quality of life might even be better for those who get a prophylactic PEG. In other words, a tube placed before they actually need to start using it. There's a study in France that's a randomized controlled trial that showed that. The risks of enteral feeding via a G-tube would be infection at the G-tube site, different GI complications such as peritonitis, leakage, perforation. The tube comes out sometimes and has to be replaced. Persistent dysphagia. I mentioned that on my slide, and I really need to clarify that. PEG tubes don't cause dysphagia, but what I meant by that was that whoever needs to be on enteral nutrition, the longer time they're on it, the less likely they'll be able to swallow and start eating again, because they lose the ability to swallow. So I left it there for the purpose to say that if somebody's on an enteral feeding, they can still eat and try to eat as best as they can while they're getting their tube feeding, so that they can retain the ability to swallow. Poor body image is a problem with anybody who gets a tube. And rarely, there are case reports in the literature of metastasis of head and neck cancer to the gastrostomy site. And I've looked real briefly at this. Over the past 20, 22 years or so, there's been real rare reports of that. So that's something else you'll see if you look in the literature. For jejunal feeding in esophageal cancer, the benefits that have been documented are maintenance of body weight and prolonged nutrition support for patients with post-op complications. And when I talk about post-op complications, that would be like an anastomotic leak after surgery or stricture. The risks are small bowel obstruction, jejunostomy site infection, dysfunction of the tube, such as blockage or clogging, and diarrhea and abdominal distension has also been reported. There are published guidelines on the use of enteral nutrition for oncology patients, and these are published by ASPEN and the European Society, which is ESPEN, as well as the Academy of Nutrition and Dietetics on their evidence-based nutrition database. Overall, nutrition support is not recommended for routine use in all cancer patients, and it's not useful in terminal or end-of-life situations. But overall, it does help to maintain weight. It helps patients prepare for surgery and for post-operative healing. These guidelines don't encompass all patients who need enteral nutrition, but they are based on the data in the literature. Objective number 3, help patients achieve nutritional goals with enteral nutrition. This is one thing that dietitians do a lot of. So for meeting goals, it's good to know some basics about the feeding, the routes, the methods, a little bit about nutrient needs, and some financial considerations that I'll talk about. It's also important to teach the patient and or the caregiver, and ongoing follow-up is extremely important. It's one of the most important things that RDs do. So first I'll just briefly go through feeding routes. The PEG is the most common way of feeding for cancer patients, with head and neck cancer, that is, and that stands for percutaneous endoscopic gastrostomy. It's placed with use of a scope And if a patient has an obstructing area in their esophagus or throat where a scope cannot be used to place a PEG tube, then a G-tube could be placed surgically. And if the patient's not able to have surgery, it can be placed radiologically. The PEG-J stands for a PEG tube with a jejunal feeding tube attached into it. And this allows feeding into the jejunum, or the upper small bowel, while the patient can actually drain the G-tube if they need to. The PEJ, the J-tube, or jejunostomy tube, is used for patients who cannot be fed in the stomach. This might be because of gastric outlet obstruction. It might be that they've had a gastrectomy. And J-tubes are typically used for patients who are going to undergo esophagectomy. Then there's the nasogastric, nasoduodenal, and nasojejunal tube. Those are for temporary feeding, and I consider temporary less than about a month. If they're going to need tube feeding for more than a month, they really should have a more permanent tube placed, because people really don't like having these tubes hanging out of their nose. The last type of tube there that I mentioned is a TEP, which stands for tracheoesophageal puncture. You don't see it that often, but it's put in, the surgeon puts in an ostomy in it for patients who have had a laryngectomy, and that's for use later on in voice rehabilitation. But when patients do have that ostomy, a lot of times the physician will put a small bore feeding tube in for short-term feeding, and that tube can be placed all the way down with the end in the patient's stomach. Feeding methods. The simplest and most convenient way of feeding for a patient with a gastric feeding tube is the syringe bolus. They can take the plunger out of that 60 ml syringe and put the end of that syringe into the G-tube and pour the formula in from a can. It's very simple, and if people want to go somewhere, they can bring their cans with them, and it's a very low-cost way to feed. I always recommend that first if there's any question about how to feed somebody. The gravity bag is for use if the patient does not tolerate bolus feeding. For example, they might have a lot of fullness, they might have reflux, or nausea, or they might be vomiting. And in that case, slowing the rate can be helpful, and they can use a gravity bag, pour a can of formula in the bag, hang it on a pole, and adjust the feeding rate with a little wheel in the tubing that compresses the tubing and slows the rate. The third type of feeding method is the pump method. It's the most expensive, and it's the one that people tend to complain more about because they don't like being hooked up to the pump. A lot of times patients on pump feedings prefer nocturnal feedings just so that they can do that during the night and be free of the pump during the day. The pump is necessary for most patients on jejunal feeding because the jejunum requires a slow, continuous rate or a controlled rate for good tolerance. Otherwise, patients can have symptoms of dumping syndrome. It's important to document medical need for that pump so that the pump will be covered. Pump rental is very expensive. And I'm going to talk a little bit about nutrient needs. For maintenance or weight gain for most oncology patients who are going to start on tube feeding, usually 30 to 35 calories per kilo is enough. Some patients with hypermetabolism or who have a lot of weight gain or a lot of wound healing to do might need 45 calories per kilo. And I've had patients that even use more than that, like 50, 55 calories per kilo, patients who are very hypermetabolic. And I tend to see that more in the head and neck cancer population than any other. If a patient's overweight, I typically start them at 20 to 25 calories per kilo. And it's important when we start patients on feeding that we adjust as needed after days or weeks because what we calculate might not be exactly what they need. They might need more or less than what we've actually calculated, so we can monitor them. And I'll talk a little bit more about that later on in the webinar. If the patient needs less or more calories, we can simply adjust the amount of formula that they're getting every day. If they need more calories, oftentimes using a concentrated formula is helpful because people usually don't like to take more cans. Protein needs are generally 1.5 to 2 grams per kilo, and I use actual weight or adjusted body weight if they're obese. And there are high protein formulas available. And if you're using a standard formula, you can add protein supplements that are either liquid protein supplements or powdered protein supplements. Water needs are 30 to 35 mils per kilo. Some people use the 1 milliliter per calorie method, but I like to use the mils per kilo method because sometimes I'm adjusting their calories up and down, and I just want to make sure that they're getting enough fluid for their 30 to 35 mils per kilo. There are patients that have increased needs for fluid, and I've put some examples there, such as those with enterocutaneous fistula, where they might be draining a lot of fluid, patients with high ostomy output, such as ileostomy, patients with a lot of diarrhea, or if the patient is draining a G-port of a PEG-J tube, draining with a gastric outlet obstruction, they might be draining a G-port, and they might be losing a lot of fluid that way. You can actually try to give back some salt as well as water, knowing that gastric fluid contains some sodium and chloride as well. Sometimes I tell people to put a 1/2 to 3/4 teaspoon of table salt per quart of water to help replace some of what they're losing. You can also have patients reinfuse gastric output into the jejunum, and that would be possible if they're on active PPI therapy. If they're acid suppressed, you can do that, and we do that in the hospital sometimes, and also sometimes at home. It's important to monitor the patient's hydration status. Signs of dehydration are less or darker color of the urine. You can, if you're seeing them in clinic, you can see skin, oral mucosa. Flattened neck veins is another sign of volume depletion. And so is rapid weight loss. If somebody loses just a ton of weight in a few days, you know that a lot of that is probably fluid. You can also tell by voice quality, and I can sense that on the phone sometimes. And also what I've caught oftentimes is orthostatic hypotension. Patient will tell me, I feel weak and dizzy when I stand up. And then I can go through and make sure they're taking enough fluid and getting their hydration needs. If you have access to lab work, you can look for dehydration by looking for hypernatremia or for elevated blood urea nitrogen. And just a couple comments about water safety. If a patient is going home on enteral feeding and you're not sure if they might not have running water, or they may have a well where the purity or safety is questionable, you can tell them to use bottled water. And especially if they're immunocompromised, you can have them use sterile or purified water or boil their water before using it. Teaching the patient or the caregivers is important, and I got a picture of an example of a tube feeding instruction sheet that I give to patients. The one that's shown there is one for bolus feedings. I tell them the formula name, how many cans they need, and how much water they need in addition to their tube feeding. I also give them an understanding of how to convert milliliters to common units of measure, such as ounces and cups and tablespoons, so that they get a better idea of what milliliters means, because they're seeing milliliter a lot when they come out of the hospital. You can teach them at all different times. When I have a patient in the hospital, I teach them or the caregiver prior to discharge. If they're in the clinic, they can be taught about the enteral feeding either before they get their feeding tube put in, or when they come for their 2-week post-PEG follow-up is a good time to teach them. When they first come out of getting their tube placed, oftentimes the patient isn't alert enough to be taught, but caregiver family members can be taught. at that time. And then follow-up. And again, I mentioned before that this is one of the most important aspects of all that registered dietitians do, and it's one area in which we have the most impact on how well a patient does. I typically ask them a bunch of questions when I follow up. I ask, how many cans are you taking of the formula? How much water are you taking? What's your weight? Are you having any problems with tolerance, such as nausea, vomiting, diarrhea? I even ask them what color their urine is. I feel like I get very nosy with them, but I have to ask all those questions so that I know how well they're doing. I've also caught tube site problems at follow-up. They might say, I'm having a lot of pain at my tube site. You might notice that there's redness or drainage at the tube site, and then you can get them hooked up with their physician about treating that. And I also ask about energy levels. I had a patient not too long ago who had esophageal cancer and was going home and was being treated with radiation and chemotherapy with plans for an esophagectomy within the next 2 to 3 weeks. And he had gone back to work, and he was feeling very weak at midday, and he was losing weight. And his wife told me that she thought he was wasting away and was really concerned about him. And I called him at work, and he said, yeah, I feel real weak, and I don't even know if I'm going to make it. I'm losing so much weight. And I explained to him that it was important to take his goal amount of cans. He didn't really understand that at first, and that he could take some cans with him to work and do a can in the middle of the day. Just like we would eat a snack or a lunch, he could have a can to help improve his energy levels and keep him well nourished prior to his surgery. And some safety tips that I'll talk about. With medications, it's important to flush with water before and after giving, especially if you're using a small bore feeding tube, such as a J-tube. Don't mix meds because you don't know if that could clump or if that could cause chemical interactions or could change the drug stability. Don't crush sustained release tablets. That could cause a big overdose for a patient, or it could clog tubes. And in general, we don't mix medications with enteral formula because we're not sure if that affects bioavailability. And then to prevent enteral formula contamination, it's important that patients and caregivers know about aseptic technique, keeping the tops of the cans clean, keeping their syringes clean like they would their dishes, and washing their hands and that kind of thing. And then the hang time for ready-to-use enteral nutrition that's poured into a bag is 8 to 12 hours. And for the situations in which they might be using a ready-to-hang system, you can hang it for much longer. If they're using a feeding bag or a gravity bag for feeding, then they would need to change that every 24 hours or every day. Financial considerations are important. If a patient has health insurance, this will dictate which home health company that the patient goes with, including if their infusion company is going to be able to take care of their bill. And they're the easiest patient to work with because you know what their insurance covers. If they have Medicare, there are specific guidelines, which I'll talk about in the next slide. And if they do not have insurance and have to self-pay, that's when they're the most challenging to work with because especially if they need a pump, it's really hard to get them what they need without having to spend too much money. They can compare costs such as pump rental, feeding bags, and formula, and so forth. They can compare with different IV infusion companies versus self-purchasing their formula from a pharmacy versus a DME company, durable medical equipment. In some cases, it might be better for a patient to actually buy their formula from a pharmacy rather than an infusion company, depending on if they have insurance or not. And this is Medicare coverage guidelines. An example, I'm going to just go through these and then tell you some examples. The first one and the most important one is the patient has to have a diagnosis of either A, a permanent non-function or disease of the structures that permit food to reach the small bowel, or B, a disease of the small bowel which impairs digestion and absorption of an oral diet. An example of a Category A patient would be somebody with head and neck cancer with a tumor that they can't swallow. An example of a Category B patient would be someone with a partial small bowel obstruction, a patient with pancreatic cancer that is not digesting and absorbing well, might need an elemental formula, or for a patient with radiation enteritis that might need an elemental formula. The second main category or criteria for Medicare coverage is called test of permanence, and that means that the anticipated need for the tube feeding must be 3 months or more. If it's less than that, Medicare will deny it. So even if they meet the diagnostic criteria, if they don't meet test of permanence, they won't be covered. And thirdly, they need to have enteral nutrition by a tube to maintain weight and strength. So if they are able to drink all of their nutrition, they would not be covered. But if they are able to take only a small amount by mouth, and there's a lot of patients like that that can take only a few sips and bites during the day, they are covered still. And even if they can take little bits of food by mouth, they would still be covered as long as they cannot take enough to maintain weight. In some areas of the country, there is a calorie requirement also of 750 to 2,000 calories. Now, where I am practicing, we do not have a calorie requirement. I've never received a denial based on that. The only thing I've had questions about is protein supplement. Why are you using a protein supplement? And one thing to keep in mind is that Medicare covers, whatever Medicare covers, it covers 80%. So if a patient doesn't have a secondary insurance, they need to know that they're going to be covering 20% of that. The OLI Foundation is a support group. It's a national not-for-profit organization. They have regional meetings around the country, and they have a publication called Lifeline Letter for both clinicians and patients and caregivers, and that's free of charge. People can sign up for that. They have information sheets about feeding complications for both parenteral and enteral nutrition patients. They have a telephone hotline and an online chat forum. Another thing they have is what they call equipment supply exchange. So if you have a patient that's not covered or a patient that has formula that doesn't need it anymore, they can actually donate it and give it to someone who needs it. The OLI Foundation makes pamphlets also, and you can get a pamphlet and make copies of it and give it to your patients who are starting on nutrition support, whether it's enteral or parenteral. And it's a good idea to give that to them right when they start out so they know that they have that support available. I'm going to go back to our clinical case just to reorient you to it. The 55-year-old with esophageal cancer who's had a feeding tube placement, and he's going to have an esophagectomy in the near future. He's not able to eat anything and not able to eat much, and he's lost a whole bunch of weight. And I want to remind you, too, that after this webinar, I have some study questions that they're in sort of similar to this format. They're case-based study questions, so you can test your knowledge. But I just have this one to give during the webinar. So the questions that you might ask is, does he need enteral nutrition? What does he need to take more of besides enteral formula? Which feeding method is appropriate for him? And what are some criteria that we want to monitor as he's using nutrition support? And the answers here are that, yes, he does need enteral nutrition to prevent continued weight loss, and he also needs to maintain his strength and his nutritional status to prepare for surgery and to help with postoperative healing. He does need to take something besides the enteral nutrition. He needs to take more water flushes via the J-tube. He's told us that he has dizziness and his urine is dark, dizzy when he stands up. So he does need to take more water. And I run into that water thing a lot with patients. He needs a pump for feeding. He's got a J-tube, and most patients who are fed jejunally will need a pump to tolerate it well. And some of the things that we're going to monitor is the amount of formula that he's taking, his water intake, if he started any oral intake. Sometimes when they start their radiation, their tumor shrinks somewhat, and they can actually start eating again. So depending on how much he's able to start eating, he may or may not need so much tube feeding. And I also would check bowel regularity because he complained of some constipation. And if that gets bad, he won't be taking his formula. He'll be too uncomfortable. So that's an important thing to keep watch on. And now we're ready for objective number 4. This is to implement methods to troubleshoot or minimize problems during enteral nutrition therapy. In other words, how can I help patients overcome problems? And this is one of the hardest parts of dealing with patients on enteral nutrition. There are many problems that nutrition support clinicians can help with. And these things I deal with on a daily basis. And there's way too many that could be talked about in this one lecture. So I'm going to focus on just 6 of them. 2 of them are one is refeeding syndrome and one is Chyle leak. They are not extremely common, but there's things that are common more so in the oncology population than in others. And then the other things I'll talk about is the regular usual GI complaints such as nausea, vomiting, diarrhea, and that kind of thing. So refeeding syndrome. Who is at risk for refeeding syndrome? This would be any patient who is severely malnourished, any patient with poor or no nutritional intake for 7 days or more, and those with excessive alcohol use prior to you seeing them in clinic or starting nutrition support. Those will all be at risk for refeed syndrome. There are 3 main aspects of refeeding syndrome. The first one is a rapid and severe decline in serum potassium, phosphorus, and magnesium. This is probably the most well-known aspect of refeeding syndrome. Fluid overload is another one. It's important to remember that a cachectic patient cannot tolerate large volumes of fluid. They can get pulmonary edema, or cardiac decompensation can occur. And this would especially be of concern if the patient's in the hospital getting intravenous fluids, sodium-containing fluids. They're likely to get overloaded if you start them on nutrition support and then they stay on their IV fluid. So one of the things I always recommend to the physician is please decrease the IV fluid when the tube feeding gets to such and such a rate. You know, when it gets near the goal rate, when I think that that's enough fluid for them, I want them to decrease the IV fluid. And the third part of refeeding syndrome is manifestation of B vitamin deficiency, and most notably that would be thiamine. Thiamine is needed for decarboxylation of pyruvate when we're going to use our nutrients and convert them to calories. There's an increased demand for thiamine with carbohydrate intake. And patients who are malnourished will have diminished blood levels of all the vitamins and electrolytes, but thiamine is the most important one because patients can develop Wernicke's encephalopathy, which is a severe form of thiamine deficiency. Not too long ago, I had a patient that I started on tube feeding in the hospital, and she came in with the classic sign of Wernicke's encephalopathy. And it's important to give these patients multivitamins and extra thiamine. And if they do have signs of Wernicke's, definitely they would need a lot of thiamine. Severe hypokalemia, hypophosphatemia, and hypomagnesemia occur in patients if they're having refeeding syndrome, and the symptoms can be range from cardiac arrhythmias, and they can range all the way to death. Refeeding syndrome can actually be deadly. A couple things about phosphorus. Phosphorus is the most likely to go down in refeeding syndrome. It's used up in glucose metabolism. It's used in ATP production. And phosphorus, potassium, and magnesium all move intracellular due to the action of insulin when a patient starts receiving carbohydrate. So when you get a depleted patient and they suddenly get carbohydrate, you're going to have these electrolytes moving intracellular and going very low in the bloodstream. And also interesting with phosphorus is that it's needed for 2,3-diphosphoglycerate, which decreases the affinity of hemoglobin for oxygen so that oxygen can go to the tissues where it's needed. So to manage and prevent refeeding syndrome, the main thing to do is to underfeed the patient for 3 to 5 days. What I typically do in practice is to start at 15 to 20 calories per kilo of actual body weight and then move up very gradually, maybe 200 calories or less per day. The main thing to remember is underfeed for several days, and don't increase the calories if the potassium, mag, or phos are low. The electrolytes should be monitored daily. If that's in the hospital, that's easy to do. If the patient is going home, I try to get electrolytes checked on day 3 or 4, or day 2 or 3, or day 4 or 5. I try to give a little bit of leeway for the nurse to get the labs because I know that they have to adjust their schedule to do that. But I like to get them a couple times during that first week. And if they are going home at refeeding risk, I usually keep them on a lower calorie level for a whole week. And again, avoid excessive fluids. They still need to get adequate fluids, but not too much. And vitamin supplementation is important as well. I'm going to talk about Chyle leak. It's a rare thing to see in an enterally fed patient. It's a rare thing overall, but the patients that it's more likely to occur in are those in the oncology population. Chylothorax occurs from malignancies such as lymphoma or metastasis to the lymphatic system. It can also occur rarely during neck or thoracic surgeries, so we see it every now and then in post-esophagectomy patients. Chyle is a white fluid that normally enters the bloodstream from the thoracic duct, and the fat content of it that makes it look white is from the intestines after digestion of long-chain fatty acids. So it's enteral intake of fat that affects chyle drainage. The goal is to limit dietary fat to minimize chyle flow, and minimizing chyle flow with the hope that the patient's chyle leak will heal. There are certain situations in which the chyle drainage still won't decrease, even if we use this very low-fat elemental formula that we typically use. And in those cases, a patient might need to use parenteral nutrition. If the leak does not heal within 1 to 3 weeks, sometimes less than that, oftentimes the doctor will want to do surgery to fix the chyle leak. But the formula we use is a very low-fat elemental formula with a good proportion of medium-chain triglycerides. And I do want to just mention that for patients on parenteral nutrition, or TPN, IV lipid is fine to use because the fat that's not well tolerated in chyle leak is enteral fat. Okay, now I'm going to talk about the GI problems that we hear about a lot. Nausea, vomiting, and fullness distension. One thing I recommend if a patient's complaining of nausea is anti-nausea medications on a scheduled rather than a PRN basis. Sometimes that's really helpful to them. I can do smaller boluses if they're on bolus feeding or decrease the infusion rate if they're on a pump. It's important to have upper body and upright position. And if they have a PEG J tube, they might need to drain their G port. They might have a gastric outlet obstruction and have a buildup of gastric fluid and need to drain that while they can still feed in the J tube. A lot of times over the years I've caught patients vomiting enteral feeding when they were fed jejunally. And in that, when you catch that, that means they're either obstructed because their jejunal tube feeding is coming up the wrong way, or their J tube is malpositioned. And what I've found in practice is that usually it's a malpositioned J tube. So when they're vomiting, I ask them, what does your vomit look like? And if it looks like enteral feeding, I can get them to go to the clinic and have a new J tube placed or have it positioned correctly. Prokinetic meds can be used if the doctor is okay with that. That's something you have to discuss with the doctor. And if a patient's getting fed in a gastric feeding tube and they just cannot tolerate, and you've tried everything else, they might need a post-pyloric feeding. They might need a J tube. In some cases, a lower fat formula may be helpful. For example, if a patient's got pancreatic cancer or maybe had part of their pancreas removed and they're not digesting well, if you get fat, undigested fat into the end part of the small intestine, you can have what's known as ileal brake, which is a slower motility problem when fat hits the lower small bowel. And if a patient has fullness and distension, you can try lower feeding rate. You can try avoiding fiber because that contributes to gas production. You can rule out constipation as a cause, which is really important to make sure that they're not having this because they're constipated. And if they're not using their goal amount of enteral nutrition, they can try a more concentrated formula, such as a 2 cal per mil formula. I do that a lot. I want to mention that if patients are complaining of distension, it should never be taken lightly. I had a patient once that was complaining of distension, and he was told to take laxatives, and he did. And every time he fed, he was in severe pain. And he kept trying to feed and kept complaining of severe pain. And he was on the phone with me as well as his wife was on the phone, and they said they had to stop the feeding, and they told me that his abdomen was very distended, and he was in a lot of pain, and he had developed a fever. And I told them to go to the nearest ER, and they did, and I was glad they did because he actually had bowel obstruction. So I never take fullness or distension lightly. I always ask a lot of questions if a patient complains of that. Some of the causes of constipation, patient may have pre-existing constipation before they ever got cancer or before they ever started on a tube feeding. So there's a lot of different reasons they could have constipation. One of the things that contributes in the cancer population would be opioid-induced constipation from those who are using high-dose pain medication. Other cancer-related causes for constipation would be tumor invasion, causing obstruction of the bowel or affecting the nervous system. And then other things to consider, like I mentioned in the last slide, obstipation or obstruction. So constipation can become something very, very serious. The treatments for constipation would be sufficient water intake. And if the patient can take sufficient water and that's still not helping, sometimes fiber can be helpful. It's important not to give fiber until they start stooling, though, because you don't want to contribute to an obstruction with fiber. The most mild remedies would be stool softeners, and then next in line would be stimulant laxatives, and then osmotic laxatives. I have some patients who use prune juice in their tube and find that that works just fine. And so if they haven't been started on milk of mag or Miralax or something like that, oftentimes I tell them just flush your tube, take a quarter cup of prune juice and flush your tube again and see if that helps. And if it doesn't, they can get more laxatives ordered. And I want to mention opioid receptor antagonists. Because opioid-induced constipation is a problem in cancer patients, sometimes it can get so bad that it's not responsive to laxatives. And there are drugs that will prevent the peripheral effects of opioids on the bowel. And those are naloxone, methyl naltrexone, and elvimipam. These are being studied both here and in Europe. And methyl naltrexone does have a FDA labeled indication for use in opioid-induced constipation. Naloxone and elvimipam are non-FDA labeled indications. But it's good to know about those if you've got patients that are really non-responsive to laxatives. And I saved diarrhea till last because we hear about it so much, and I thought by the end of the talk maybe people will really want to hear more about diarrhea because we hear about it all the time. It's the most commonly reported side effect for patients on enteral nutrition, and there's no standard definition of it used in studies, so it's hard when you look at the literature to really get clear answers. In general, it means more frequent or more loose stools, but again, frequent and loose doesn't necessarily mean diarrhea. We do not know that there's a multitude of causes. I've listed some of the causes of diarrhea here, and there's a whole bunch of them, and I'm not going to go into all of them, but I would suggest that if you want to know more about this, that you look at the archived version later, because a lot of times tube feeding gets blamed for diarrhea, and I think we need to look into a lot of other possible causes. And I can give you an example. I had a patient recently that was on sorbitol and had loose stool and discomfort, and all she did was she changed to a, she wasn't on sorbitol, she was on Roxicet, which contains sorbitol. And all she did was change to a crushed tablet instead of the liquid Roxicet, and she was able to not have her symptoms anymore. Another thing I want to mention is if you do hyperosmolar feeding into a stomach that, in a patient with that had a partial gastrectomy, or if you do that into a jejunal feeding tube, you can get dumping syndrome. So it's important that if a patient has a J-tube, that you feed them with a pump. And I wanted to mention on that, I had a patient who, her daughter was feeding her, and they didn't want to use the pump anymore, and she had a J-tube. And so she just started giving the feeding as a bolus in the jejunum, and the patient was complaining of really bad cramps and diarrhea after each feeding, so they just stopped doing the tube feedings altogether. And this lady lost a whole bunch of weight. She came back into the hospital, and I said, well, why wasn't she getting her feeding? And the daughter said, well, she has diarrhea. Well, that's what I found out, was that she wasn't using her pump anymore. She was bolusing into the jejunum. So it's a good thing to check on that when patients complain of diarrhea. So importantly, ask questions. Another patient that I had told me that he wasn't having any stools. So another caregiver on the healthcare team told him to take laxatives. And I saw him in clinic, and I asked him, are you having stools yet? And he said, no. And I said, well, did you take laxatives? And he said, no, I'm not going to take laxatives. I've got water coming out of me. So, and that was an example of there was just a lack of communication. He said he wasn't having stools, but what he really meant was he was having diarrhea, and we thought the opposite. So for diarrhea in general, what I recommend is to remove any medications that may contribute to it, such as potassium or sorbitol-containing liquid medications. Check for infection. Try smaller bolus feedings or a slower feeding rate if the other two items don't apply. Sometimes adding soluble fiber can be helpful. And make sure you're using the correct feeding method. For example, use a pump if they've got a small bowel feeding. If a patient has GI dysfunction, such as, let's say they have pancreatic insufficiency or they've had a lot of their pancreas removed, they might need a low-fat elemental type formula with MCT oil. Or they may need pancreatic enzyme replacement, such as Creon. Rule out obstruction or impaction, because sometimes diarrhea or loose stool can come out around an impaction, and treat infections. If all else fails, you can use antidiarrheal medications such as loperamide, codeine, and usually a last effort would be tincture of opium. In chemotherapy-induced diarrhea, which is still very poorly understood, sometimes that even antidiarrheals don't work well, and the doctor will order octreotide. So for more information on nutrition support, I recommend going to the ASPEN website, the Academy of Nutrition and Dietetics website, and the Dietitians in Nutrition Support Dietetic Practice Group has a newsletter and continuing education. What I didn't put in this slide was that you can get what's known as CNSC, Certified Nutrition Support Clinician certification, and that's through the National Board of Nutrition Support certification. You take an exam every 5 years, study for the exam, and retake it every 5 years. And that is through ASPEN. And lastly, I want to mention that here at UVA on our website, we have nutrition articles in practical gastroenterology, and we've got a ton of articles that cover in depth almost any nutrition support topic you can think of. I've listed my references here if you want to do any reading on your own or learn more about any of these things. And I'm ready to take questions if you have them. And if you think of questions later, you can go to and email me. My email address is listed.
And Theresa, thank you so much for the presentation. We will go over 3 or 4 questions since we do have quite a few questions, but those questions not answered will be put together in an FAQ and posted on the nutrition site. So are you ready for the first question?
Yeah.
Okay, the first one is, what formula do you think is best for jejunal feedings for cancer patients?
For jejunal feedings, I would use just a standard 1.5 cal per meal formula. That's what I use a lot. You don't need anything special. Unless they have, problems with digestion absorption because of maybe pancreatic problems, you should do fine with the standard formula.
Okay, great. Can you make your own homemade organic formula with juicers and not use the standard canned formula?
If you were really careful to add to give all the protein you needed, you'd have to have like a protein powder supplement. You'd have to make sure the patient's getting enough carbohydrate. So if you knew exactly what you were putting into your recipe, yeah, then you could probably do something like that.
Okay, thank you. Next question is, which calculation do you use for adjusted body weight? Do you adjust the same for both overweight and obese patients?
We do actual weight minus ideal times 0.5, the traditional way that dietitians have been doing for many years. And so actual minus ideal times 0.25. Did I say 0.5? I meant 0.25. And then add that to ideal.
Okay, and one more question. Do you have any recommendations, comments regarding the use of enteral nutrition in the blood and marrow transplant population?
Could you repeat that?
Sure. Do you have any recommendations or comments regarding the use of enteral nutrition in the blood and marrow transplant population?
I think as long as they don't have mucositis, that's, a lot of times those patients will have really bad mucositis, and so nobody wants to put a nasoenteric tube down. But if they already have a tube or if the mucositis is not so bad, then they can be fed enterally.
Okay. Perfect. And I guess I'll add one last question since we're almost at the end line. Do you recommend an MVI during treatment?
You mean multivitamin?
Yes.
Most of the formulas, I do recommend multivites if the patient is severely malnourished, and that would go in with like the refeeding syndrome recommendations I gave. I would add a multivitamin, either an Enteral or, it would be an Enteral multivitamin, like a liquid multi. If they're super malnourished, if they're not extremely malnourished and you've got them on a standard formula at their goal, they're going to be getting enough micronutrients from their formula.
Perfect. Thanks so much, Theresa, for answering those questions. I guess we will go ahead and conclude today's session, but I do want to remind everyone to visit ACCC's nutrition website to take our self-test and find out how much you know about enteral nutrition. Finally, please complete the evaluation in order to obtain continuing education credits. An email containing information on how to access your certificate will be emailed to attendees shortly after this webinar. This concludes the webinar. Thank you all so much for attending, and I hope that the webinar has been beneficial to you and your center.